You know, we started just sending them a note with a style guide that says, hey, I think you might want to relook at your story and consider this. And that's one of our nicer notes. And so in some of these questions, you know, for us, we ask these questions like, is HIV relevant to the story? If it's not, you don't need it in the story. A lot of times it'll be like, you know, mayor of Indiana rapes 3-year-old, maybe HIV positive. You know, and it's like, well, is this organic to the story? We're just putting it in to show this mayor, this guy's a monster, right? You know, but it may or may not even be true. That's what you're telling us. So that's a case of where there's nothing. A lot of criminal reporting that we see has HIV in it, but they have the facts all wrong. They'll say something about HIV transmission when the supposed perpetrator doesn't even know whether he has HIV. You know, things like that. So. Don't rely on hearsay. This is, you know, the source for the diagnosis. Don't rely on hearsay. If their status is relevant, make sure that you have the right source and you have the right diagnosis and you have a reason for publishing it. And remembering what the accurate language is to use. There's a lot of stigmatizing words. We see it in a lot of our own media, and a lot of LGBT media is still doing it wrong. Things like full-blown AIDS. There's no such thing as full-blown AIDS. You either have AIDS or you don't. It doesn't blow. You know, for us, we separate the term. We don't use HIV/AIDS for us. I know many others still do, but it's generally, you can't have AIDS without HIV. So in almost all instances, HIV works unless we're talking about a clinical situation in which somebody has actually converted to AIDS, which many organizations are talking about changing that to HIV 3. Is that what stage 3? So it would be stage 3 HIV. So
that's bleeding edge, though.
That's
a whole other conversation.
We haven't adopted it. There's a lot of argument, but it's something your media should definitely be aware of because it's really interesting whether we're going to make that change and why people want it and why people don't want it. I think people do think of HIV and AIDS as something very distinctly different rather than like stages of the same disease. We find the statistics around people knowing how HIV is transmitted are alarming. One of the statistics last year was that 17% still think you can get it from if you're in a toilet seat or a swimming pool. There was an alarming percentage that believe you can get it from utensils. I mean, over half of people believe you can get HIV from sharing a fork with an HIV positive person. Over half, you know? If any of these things you're thinking, oh my God, I thought that was true, you know, don't feel bad. You're with half of America. But do try to get the facts and find out. So I've been talking a lot and promoting my own stuff here, but what I want to do...
We like your stuff.
Aw, thanks, darling. I want to bring it out to the panelists to talk about you know, language and stigma and modeling language around HIV that's non-judgmental, and the lessons you guys have learned or resources you've used and any of that. Throw it out.
Well, in terms of resources, first of all, it's always a pleasure to get to forward to journalists through the work that I've been doing at Positive News Network USA. The HIV Plus style guide with similar notes to the ones that you described, though unfortunately, again, policing mainstream media around the use of language in HIV is kind of like a game of whack-a-mole, you know? It's the sort of vexing question around in this work around HIV and language and media is how to reach the folks who don't come to the NLGJA conference to an HIV media language panel to stay up to date. So I've done it at this point in the past number of months, a lot of kind of trainings and conversations between, you know, in the community and with health departments and ASOs around language and stigma. And one thing that I sort of tend to ask groups is, you know, folks who have, and these are oftentimes folks who have been engaged with HIV for a really long time, is what's the term that you hear frequently that you wish would just kind of, that would just go away? You know, full-blown AIDS is one that comes up a lot. One that I'm just going to put out there is to never, I think that this is a mistake as well, refer to either people living with HIV or these consenting sexual partners of people living with HIV as victims, which is something that happens.
Or sufferer.
Yeah, exactly.
AIDS sufferer.
AIDS sufferer.
AIDS
no.
victim.
Just no on that. But in terms, in terms of the victim language, it can get applied in terms of sort of AIDS victims. A term implying defeat. Anyone knows what quote that's from. But also what I've seen in mainstream media quite a lot is the framing of the partners of people living with HIV as somehow being victims. And unfortunately, the existence of laws criminalizing HIV status essentially in well over 30 states substantiate that claim of victimhood to journalists. So when I've reached out and said that these are consenting sexual partners, they're not victims, they say, well, this law says that, having sex while living with HIV and sort of allegedly not disclosing is a crime where I'm sitting. And until we don't have those laws and remove that justification, this is going to be an ongoing challenge and an ongoing wave of writing to change that.
Even children who are perinatally infected, the innocent victims. So it takes it like one step further. Meaning, there's our victims that deserve it. There's also even more subtle ones like HIV infected. I get a lot of writers who will use that term when you can just say HIV positive.
Or HIV patient, unless you're actually at a hospital, you're in a clinical setting, that's fine if you're talking about this doctor's patients. Otherwise, they're not patients. They're just people.
And that's where a lot of the language gets all muddled, because we are talking about something that's medical, and somehow people can't extract, when you're talking to consumers, meaning people, versus talking to an audience full of doctors or other kinds of providers. There's different kinds of language, and one of my big pet peeves is the infected thingy. I can't. Just drives me crazy. Because it just perpetuates this one virus as the thing that people are infected with. You don't say infected with, choose your virus. It's just not, it's this virus that's infected with. It's like, God damn it.
You're infected with the flu.
Right, really?
Right.
We are? I mean, we just have the flu.
Right, exactly.
Yeah, let me just, from our perspective at CDC, this kind of information and this type of, this work is really important, because one of the things that we do internally, because we put a lot of information out that's captured by mainstream media, and one of the things that we are doing consistently is looking across our division and all of the publications that come out and ensuring that the language is appropriate, and there's actually a group that looks at this on a regular basis, at least annually, and we basically provide guidance to all of our scientists on appropriate language to use in publication and so forth, so that it's not stigmatizing, that it's actually accurate and consistent with mainstream use of language, with mainstream gay media use of language, etc. So one of the things, this is really important and helpful to us.
And I'm actually very glad to hear that the CDC is mindful of that. But one of the concerns that a lot of us kind of always butt up against with the CDC and other governmental agencies is exactly that even though you guys are paying attention and are trying, which is great, that's where we come in. Because you have to say things a certain way, and you have to say certain things, and we get to say them differently. And
No, that's important.
yeah, so.
And also remembering the clinical information that comes out of places like the CDC and the World Health Organization and stuff can be really different than how you're reporting on people. For us, a lot of studies use men who have sex with men because many of those men don't identify either way, or they haven't to the clinician there. For us, whenever possible, we just say gay and bi men. And that's not just because we're willing to label you, which we are, but it is more that that MSN is sort of this sort of like weird classification that is very clinical and is sort of a scientific term more so than a real life social term. So if they've used it in a study and it's necessary to report on that study, we'll use it, but otherwise our classifications would be gay and bi men.
And I just want to kind of just say, just nakedly, that obviously it's not our job as the media to police the media or police ourselves in this respect. These are suggestions, these are the things that could help the activist side of things, but just the brain of journalist hat for a second. Obviously you need to say what you're going to say and you're going to do what you're going to do, but I would strongly suggest that, the mainstream media, since the LGBT's one, takes a lot of cues on how to cover LGBT things from LGBT media.
Yeah.
So if LGBT media could help on this front, that's actually a big assist to getting mainstream media on the same page.
Yeah, absolutely. I mean, the coverage of PrEP in the mainstream media, hold it just a few minutes and we're going to get to them.
I'm mainstream media.
Oh, awesome. Mainstream media takes a lot of cues from us, and you can see that on the PrEP coverage lately. I mean, that came out of LGBT media and HIV media, and it's just bloomed into mainstream at this point. So I'm going to throw out one more term that I actually get a lot of feedback on, and then we're going to open it up to questions. That's good with y'all.
Yeah.
Okay. So my other one is we no longer use unprotected sex. And the Center for Disease Control and Prevention has already announced it doesn't use that term to mean sex without a condom, because now there are other ways of preventing HIV transmission, or other ways to have safer sex. We don't use safe sex either, because no sex is safe, so we use safer sex in that case. And if we mean without a condom, we say condomless sex, because the person could be on PrEP, this person could have an undetectable viral load. There's so many different ways in which you could be having safer sex at that point, so the condom is one option at that point.
And some of that came from reports that an individual's on PrEP, but they're still having unprotected sex. Well, PrEP is protection, so it's like you can't. You're speaking on both ends, so.
Yeah, right, exactly. Or again, you're in a monogamous, serodiscordant relationship, but the partner with HIV is an undetectable viral load and is, highly unlikely to transmit. Those are all these different things.
I'm just really glad you brought that piece up. I mean, in terms of treatment as prevention, essentially, just to make sure that we're all on the same page with that. A partner who's living with HIV and who's on successful treatment with a low or undetectable viral load, that's prevention as well. I mean, that's protected sex right there, and that's something that that's the best news ever in HIV. I'm shocked not to see it on the front page of every mainstream paper every day,
and that is at least part of the master plan. Right. Is basically is early treatment as prevention. Get people into treatment as soon as possible, get their viral load undetectable so that we prevent it. So it is part of that master prevention plan.
Yeah. And of course there are complications and complexities around, getting people into treatment, or making sure that they're ready, and barriers to staying in care. And at the same time, I mean it's huge.
Yeah, absolutely.
And these are all things that CDC is actually focusing on as part of, as we've already started, but it's really highlighting the strategy, and that is the treatment as a primary prevention tool, and of course ensuring that you get people diagnosed, get them on treatment as soon as possible, because we also know that if you start people on treatment early, they're more likely to have healthier lives and also more likely to stay in treatment if you get them in early. And then the other big part of what we're doing, which is going to be a big part of the things as we move forward, we know that about 60 to 70% of people who know that they're positive are not actually able to support them in the way that we should to keep them in treatment. So getting people linked and re-engaged, and that having that re-engagement in care be sustained by addressing many of these structural barriers, et cetera, is really important, because we know that if we can keep people in care, keep them virally suppressed, get them virally suppressed, they're going to stay healthy, and it's going to have the greatest impact on decreasing transmission to partners and loved ones. So treatment as prevention is key. And of course, PrEP, to me, is also an important part of that armamentarium, because it's really important that we do something to help with folks who are HIV negative and virus
negative. Just to quickly piggyback off that, one half a sentence, I know we have to get to questions, but a key aspect of that, of retention and care, and there's this crater in this HIV care continuum between being linked to care and staying in care, emerging studies are showing, is trauma-informed approaches to primary care, and recognize and making sure that the entire environment of care provision, in HIV and hopefully eventually beyond, recognizes that the majority of people who come through the doors may have a past experience of trauma, and that clinical engagement is not re-traumatizing of the individual. I mean, there are studies that are showing that retention and care piece is really linked to the trauma-informed the trauma aspect, it was great to get to see that strategy.
Okay, all right, we're going to open it up to questions. We start with Mr. Mainstream.
I'm Val Nicholas. I'm Vice President at NBC News, and this thing is awesome. And the one way to get this information across an organization as big as ours is go to the person who runs standards and practices. For us, it's a guy named David McCormick. And when you get this stuff to David, what ends up happening, he's the law. So this goes to all of the producers, all of the writers, all of the executive producers, all of the people like me. It comes out of standards and practices. That means it's the law, and everybody will follow it. Trying to get to individual producers, and again, we have, 5,000 people. It's going to be impossible to get them all. But if you can, at any big organization like ours, if you can get to whoever's running standards and practices, get this stuff to them, it will go to everybody. And that's what I plan to do when I get back with this stuff. And you can get it to me. But if you're having that trouble, standards and practices is the place to go. They're like the style book for whatever organization.
Okay.
I want to ask about PrEP. I consider myself fairly, I'm a news hound and I follow things, we all are. It was only after a conversation that I recently had both with my doctor and with a couple of folks with the AIDS community in Toronto that I learned that there's a lot of misuse and abuse of PrEP. There's a lot of misinformation about PrEP out there in terms of.
Well, there have been whole misinformation campaigns about PrEP by organizations, yeah.
But it doesn't seem to be resonating in the community and in the general population. You asked in the very beginning, do we all know what PrEP is? If we're at the point where you have to ask, do we all know what PrEP is it too soon to be talking to media organizations, even gay LGBT media, about sort of the day two story? Not just what this is, because my question to my doctor was, if it's so great, why isn't everybody on it? And that's a question that I don't hear a lot of people asking in the community as well as in the media. So my question to the panel is, what stories do we need to see and how do we get them? Is it the what is PrEP story, or is it the this is how it's being used and abused and misinformation story?
I think there's a little bit of regionalism at play, because I think everybody, we all come from different regions, so we can probably each report a little bit different perspective on what we're hearing in our communities in terms of people, what they do know about PrEP, where the abuses are, and that kind of stuff. I think that I'll let the rest of the panelists address that, but I do think that there is a level of regionalism in terms of that, and I do think that there are certain publications where we're just way beyond, certain media outlets are just way beyond the what is PrEP story. And so, but of course, if your region isn't or your publication isn't, then starting with the what is PrEP story is a great basis. We did, at The Advocate, we did 31 days of PrEP. So we did a PrEP story every day for an entire month that started out with the basic what is PrEP, what is it for, why would anybody use it, what are the dangers, why does AHF not want you to use it, all these different kinds of things that got down to it. And we talked with several experts and also physicians who are prescribing it and stuff like that. So the general consensus that I hear is that there's a lot of myths about the abuses of it. People that don't have information are not necessarily taking it.
Myths about abuses?
Yeah.
So the abuses
are a little hyperbolized.
What are we
yeah.
talking about that are abuses of PrEP?
Yeah, I think that, here's the thing, is there are some people who say, oh, well, you'll get on PrEP and you just take it and you don't follow any of the things, you don't get your test to check every 3 months.
Well, people aren't using, now we're getting into sort of community stuff instead of media, but there are a lot of guys
They're interrelated.
There are a lot of guys who go on PrEP and they say, oh, I don't have to use any condoms anymore, and, you know.
Well, look, studies have shown they don't have to use condoms. That's the bottom line.
Can we back up a little bit? Maybe I can start.
But my understanding from the medical people in the medical community that I've talked to is that condoms are more effective. Condoms without PrEP is more effective than PrEP without condoms.
Not statistically, no. Not out of black studies.
Can I say a couple
That's
things?
absolutely wrong.
First of all, let me
So
just,
you're better off taking PrEP and not using condoms?
Yeah.
no, let's just back up. Let's just back up one step.
The scientist is
Yeah,
like,
let's
wait.
back up one step. Let's just say nationally, knowledge about PrEP is very low, both in people who probably would benefit from it, as well as providers who should know about it. So that's one of the big areas that we're spending a lot of time trying to address, both provider and consumer knowledge. And it varies by the community that you're in and the population that you're trying to serve. So for example, if you look at young MSM, and especially young black MSM, knowledge about PrEP is almost non-existent. So I think as a media person, you sort of need to, you know who your audience is, and it really is incumbent upon you to try to make sure you understand some of the information or misinformation that might be occurring in that community. There is a lot of misinformation out there because
Misinformation is coming from doctors.
And it's coming from doctors.
It's coming from doctors, and we're hearing that a lot.
I mean, my doctor is gay, so.
That
doesn't matter.
anything.
So we're working with
No
a number
dishing
of.
on your doctor, just it doesn't mean.
Now, if you're in San Francisco, for example, or New York City, or even in probably a lot of California, then this may not be as big an issue. So starting with what is PrEP might not be the right thing to do. But in rural America, in Indiana, in southern Georgia, etc., starting with what is PrEP is important, both for the consumer as well as for the providers. And there's a lot of effort being done both by CDC and many of the healthcare networks that are supporting PrEP, like HIVMA, which is the HIV, the Association of HIV/AIDS Medical Providers, etc., and a lot of other practitioners that are doing it. So it's a big problem. So there's a huge knowledge gap that needs to be addressed.
We called the Gay and Lesbian Medical Association, and they could not find one single physician who could talk with us about how HIV works with transgender hormones, for example. So it means that that people in these organizations or people who are, we expect people who are LGBT to be more knowledgeable in these subjects because these are LGBT subjects, but it doesn't always necessarily get a filter all the way down the latest science.
There have been national PrEP guidelines now that's been published for more than 2 years, and then there's been a lot of effort to disseminate those guidelines. In addition, we have recently funded health departments and a number of community-based organizations to help get the message out about PrEP, which is something that's new, and we're pushing it very hard.
But now you're telling me that the information I'm getting from my local AIDS community organization, AIDS service organization, which was in line with my doctor, is incorrect. So if the AIDS service organization's information is incorrect, where does that leave the community, and what is the media's role in this?
Well, I find experts.
Well, I would think people at the AIDS service organization would be experts. I would think doctors would be experts.
I guess I would find somebody, most of the people who are experts at prescribing PrEP, ironically, are HIV doctors at this point because they're the people who've been working with these medications. It's one of the failures of the system that people are finding because we are hearing from people all over the country going to the doctors, and the doctors are saying, you don't need PrEP, it's not appropriate for you, it's got all these problems, or having other more stigmatizing interactions with their doctors and stuff. And so one of the things that we do is we talk with the doctors who actually have been working with PrEP since for years, and been working with Truvada even longer because Truvada is Truvada is a component of PrEP at this point.
So what part does the media play in breaking down all this information? Because now you're even telling me I'm misinformed.
Well,
so here's the thing.
Are you trying to respond? Let him respond.
Okay.
Bring him in. He's had his hand up for a long time.
I just did a program on this, and I had a leading HIV specialist who'd been working in HIV for over 30 years, and the executive director of our local PrEP Access Project. And he gave a great analogy that kind of helped shine a light on this. And he said, think of a toolbox, and you have your HIV prevention toolbox, and within that you have different tools. Condoms are a tool, PrEP is a tool. It's like driving your car. You have airbags and seatbelts in your car, but if you're not wearing your seatbelt, your airbag's not going to do you any good if you get into a collision.
But then you're saying use both condoms and PrEP. I'm saying that doctors are saying, or maybe that if you use PrEP, you don't have to use condoms.
So here's the direct answer. I'll throw myself on the sword here, okay? You want a direct answer to a very tricky question, and CDC guy ain't gonna tell you that. So this is what you're pressing, and this is even me being hesitant to say it, okay? The point about PrEP is that officially it's supposed to be prescribed with condoms. You're supposed to use condoms with PrEP. That is the official guidelines. No one is in any authority that is related to that prescription, that guideline, is going to say otherwise. I'm even hesitant to say in public, PrEP is okay without condoms. However, studies are showing, now real-world studies, the San Francisco Kaiser thing, this is the real world. This is real world. This is not controlled. This is not where people are literally shoving the condom in your face. PrEP works without condoms. We can finally start coming out of the closet and saying that.
And here's another component of it that we have to say. If you can tell me you have never had sex without a condom, then I'll say you're right, you don't need PrEP.
Let me just.
But that is a very, very rare person who can say that.
Now, PrEP works when it's taken appropriately. Now, that whole phrase,
That's where
taken appropriately,
concerns are.
is a huge piece of conversation that's being debated and studied at the moment. What I can say is that if you take it every day, it will work. Yes. With or without condoms.
For HIV.
Preventing HIV.
Preventing HIV, that's what we're talking about. Yeah, yes. And not to have a debate with Stephen, who's a very good friend. But I hear that pushback all the time, and it kind of drives me a little cuckoo crazy. Because, yes, that's true, but also part of the guidelines is that people are supposed to go in every 3 months and get screened for everything from their head to their toe. People are being
more connected with care.
More connected with care, and even if you do get an STI as a result of I have to police my own language, of condomless sex instead of unprotected, of condomless sex, as a result you get an STI, it's going to be caught, it's going to be treated, you're not going to die from, syphilis or whatever, because you're going to get tested every 3 months.
Yeah.
So
the abuse would be if you don't go get tested, if your doctor doesn't make you come in, those kinds of
exactly.
things. Or if you have a buddy who has HIV and you ask to borrow his Truvada tablets and you take some of them thinking those are PrEP because they're not. Those are the kinds of abuses. The condom issue.
When people don't take it appropriately, and there's many, again, definitions of that, but certainly not taking it appropriately is, I'm just going to pop it before it happens. That's a problem.
Yeah.
But again, on the flip side of this, that's, I think, more of a myth than a reality. People that are getting themselves on PrEP are actually taking a very responsible step and a clear-headed step.
And we're hearing
and we're hearing that over and over again.
The demonstration projects are
Studies keep showing, better healthcare
Studies
outcomes.
keep showing both here, internationally, studies keep showing people will meet these, are doing it, are taking it daily, are doing it. And then we're also starting to have